Hi, everyone. Thanks for joining us. We'll get started in just a couple of minutes.
A bunch of people are still signing on. It's so good to see everybody. Awesome. I hope everyone's doing well. I heard there was a big winter storm out in the mountains, so I hope everyone is staying safe and warm. Sarah, you can go ahead.
How's the waiting room looking, Sydney?
You are good to go whenever you feel ready.
Okay, cool. Hi, everyone. My name is Sarah Brayley. I am the program manager here with CPCQC, where I oversee COAIM SUD, and welcome to our February Learning Collaborative. As we get started, don't forget to enter your name, which hospital you are part of, into the chat. Here's a brief overview of what we plan to talk about for the next hour. We have Dr. Christine Gold with us to discuss toxicology best practices. We will then have two physicians from Denver Health provide a case study for us. And then we'll be going over some other items for 2024. So without further ado, I am going to stop sharing and allow Dr. Gold to get started.
All right, thank you. Let me share my screen. Give me one moment. Okay, can everyone see my slides now? Okay, great. Well, thanks for inviting me. For those of you who have been a part of this collaborative since last year, I had done a separate talk early last year about this toxicology testing guidance that we issued from Support Colorado. And so today I'm here not to just repeat that lecture, but actually talk about updates, things that we've learned along the way, and hopefully ways that you can implement these guidelines, learning from my past mistakes along the way. So I wanted to start out with this quote, which I've done some leadership courses that always talk about Cotter and change management. And really what I want to say is it really does come down to the behavior of people as we make these changes. And that's been my experience for the last year. But I will say that I've had a lot of really positive patient experiences with my work as a newborn nursery doctor in Aurora. And especially those families impacted by substance use, while we've been applying some of the concepts from this guidance, it's just made a world of a difference for us as providers and for the patients. So I think this is good work, challenging, but good work. So objectives for today, just going to very quickly review best practices for tox testing, and then discuss updates and feedback, talk about some barriers to evidence-informed principles here, and then talk about opportunities, informed consent, and next steps. So starting with best practices, in general, which this will be a review for everyone here, but we recommend that screening and testing be used differently as terms. So screening would mean verbal or written questionnaires, and testing would mean biological specimens. So we do recommend universal screening for all pregnant and birthing people, and that screening should ideally precede testing if testing is actually indicated. We do recommend informed consent for all testing when it comes to toxicology testing, including for the newborn patient, utilizing trauma-informed techniques always with all patients, but especially with this population. And that CPS reports are not automatic just for a positive toxicology test. Multidisciplinary teamwork is huge. And then in general, what we've been trying to express over the last year is that medical indications should drive medical testing, but social indications should drive social supports. And I think sometimes that gets muddled a little bit in these discussions. So I probably had this exact slide last year, but what are the overview best practices from the support guidance? One, thinking about testing indications, how can the test be helpful, which it can be, like identifying additional exposures, whether that was intentional or not, demonstrating sobriety, helping to inform the safety of breast milk usage, although it's only one of many ways to do that, but also balancing that against the acknowledgement that testing can also cause harms. It can decrease trust in the relationship with the patient, introduce bias and inequities, which we'll talk about later, and impact this family in ways we might not even be able to imagine during this vulnerable state. Trauma-informed care is emphasized, consent, multidisciplinary huddles, plan of safe care and resource identification, all things we know about here. And I just wanted to show the algorithm one more time. I can't think of a way to make this look better on PowerPoint, but all this to say that it's not, we screen someone, we test someone, we report to CPS. It's a lot more nuanced than that. There's a lot of branching points, and we want to de-emphasize that kind of historical way of doing this work. All right, so that was fast, but I think we're all hopefully aware of this information. So let's next do some updates and feedback that we've been hearing since we published our document from Support Colorado last year. So we are working with the Division of Child Welfare to officially endorse the guidelines. That work is ongoing, but hasn't been officially approved yet. The policy analysis work group through Support Colorado that has tackled this document is not just stopping at publishing the document. I'm a part of that group, and we keep thinking about what are ways we can make sure people are aware of this guidance? How can we provide support? How can we collaborate with our partners here, such as CPCQC, Chosen, Moms Plus, et cetera? There are some educational videos, including one that I did on our Support Colorado tox testing guidance, and those have just been released. Chosen Quick has worked to endorse our guidance, and we are disseminating the document we made across many venues, both locally and at national pediatric conferences. Separate things that I think relate to our document. So the CDPHE cannabis and breastfeeding guidelines are done. I just don't know if they're fully published. And Chosen Quick also has their own cannabis and breastfeeding guidelines, both of which will be updated in our Support Colorado guidance document and linked, just of note. And separately, the American Academy of Breastfeeding Medicine also updated their clinical protocol about breastfeeding and substance use this past year. We are seeing more interest in hospital systems adopting the guidance, which we'll talk about. And there's two parts to the feedback we've gotten. First part, I decided to highlight the positive, which is the enthusiasm. So this is just the presence of this document and attempting to disseminate it has really prompted a lot of really good conversation. We're talking about bias and inequities in these practices. There's a lot of organizations that we've found that are working together to make this work possible. We have had a lot of enthusiasm and positive feedback from people with lived experience and people at the conferences that we're presenting this material to. This is helping to drive some collaboration goals between local CPS teams and the local hospitals or birthing facilities they serve. We've realized through the work that we've done that there's a lot of work happening in silos, and we're trying to break down those silos and make sure that everyone's collaborative and not reinventing the wheel with this work. And I think the presence of this document has helped all of that. And so lots of really good work happening, lots of enthusiasm, I would say, but there's also the concerns. And we knew that issuing a document like this would also come with concerns and questions and feedback. And so as a pediatric provider, the biggest feedback I've heard from the document is, okay, what do you mean we're going to have less indications for toxicology testing? So typically this is a really, really long list with things like inadequate prenatal care, history of incarceration, interpartner violence this pregnancy, lots of things that make me feel uncomfortable. But what we put in our document as a reminder is on the screen, which includes the birthing person test indications for signs of intoxication or withdrawal not otherwise explained, if desired by that birthing person, and if needed to help inform the safety of chest or breastfeeding. And the newborn testing indications include the same ones, plus if you see a newborn who appears to be withdrawing with those symptoms not otherwise explained. So lots of shock maybe or hesitance about having a smaller list of toxicology testing criteria. And then the idea of informed consent. So it's not new when we talk about urine tests in the birthing person, but there are some people who are absolutely shocked that we are suggesting to do informed consent also for the neonatal toxicology testing. So those are the two biggest things I've taken away as a pediatrician. Lots of other really great feedback that we've heard that I think are going to help inform next steps. So despite law changes and this guidance, I hear a lot of people on the ground, especially our social work colleagues, say, this is all great, but when I call CPS, they're still asking for the tox test results. So what's the deal? Why is there a disconnect? We also have heard from social work colleagues that we're telling them to do this a different way, but their pediatric colleagues who are telling them to make reports aren't on the same page. So how do we bridge that gap? Many people, including a presentation I did on Monday, do not know that the law changed in 2020, defining child abuse and neglect related to substance exposure. And so that's a big eye-opening moment for us to learn to disseminate that information. All this work has been focused inpatient. Our outpatient colleagues are relatively unaware on the peds side of this work. So that's another eye-opening thing that we've heard. And some people, as we talk about reducing bias and trying to reduce the toxicology testing indications, have come back by saying, well, the only way you can reduce bias is to test everybody, which we know that actually just leads to more inequities and bias in the way we respond to the tests and report. But that's the feedback we've heard that I think is going to help drive the way we approach this work moving forward. All right, so we've talked about the guidance really quickly, what feedback we've heard since it was published last year. And now I want to dive into, what are these barriers? Like why are there so many barriers to evidence-informed practices, and why did we issue this document? So I'm sorry if I get into the weeds on these slides, but I figured I'd rather have all the information here so that you guys, if you wanted the PowerPoint, could take it and have this information when you go to your organization to talk about change, but I won't spend all the time reading every word. But the first biggest barrier from a clinical perspective in my mind is that, all the major medical organizations endorse universal screening, but no one really says much about testing other than, biological methods like testing might not be needed. But there's really a lack of explicit guidelines anywhere for toxicology testing of newborns and their birthing persons at delivery. So that, I think, has led us to where we are now, where there's a lot of variation in practice. There's limited data published on who we test, and that data itself is also limited in the way it's done. Lots of confounders, study design limitations. There is a lack of validated selective criteria for tox testing. There's lots of publications out there trying to look at it, but nothing that's been validated. And then, unfortunately, this is less applicable here in Colorado, but there's conflicts between evidence-based practices in the literature and what their legislative requirements are in other states. And so I think that makes it hard to have perfectly unbiased data, essentially. So the current state evidence, I only review this. What I mean current state is that pre-issuing this best practice guideline, what are people doing? And I bring this up because lots of my pediatric colleagues who are concerned about decreasing the toxicology testing criteria number are referencing these studies to say, no, these studies support what we're already doing. We shouldn't change. And so I wanted to address these with you guys so you have some knowledge. So the evidence for current state, many selective criteria, meaning, again, not that you admit to use or that you have evidence of use, but that you just didn't show up for adequate prenatal care, et cetera. That's the selective criteria, are in fact not correlating with positive tox tests in the literature. So this Wood study is referenced really frequently. All of these studies are limited by, they were only retrospective, looking backwards. They are only at one institution, so not replicated elsewhere. And in a lot of these studies, they only looked at patients who had positive tests. So they didn't look at anyone who wasn't tested or anyone who had negative tests for a lot of these except one. So the Wood study found that the strongest association with a positive test was history of non-medical substance use and tobacco use. If you added in poor or late prenatal care, incarceration, it was a little bit higher to be likely that you had a positive test in this cohort. They didn't find any association between unexplained prematurity or untreated birthing person psych illness, which is unfortunately on a lot of policies still. And the SUN study gets referenced constantly. Again, retrospective, single academic center, looked at positive test results versus those who were chosen for testing with negative tests. They didn't look at cannabis at all. And the strongest positive association was history of substance use, like obvious, but great. They looked at a lot of other factors though, and tried to say, hey, all these other things are associated too. Like if you're single, as opposed to in a relationship, if you lack employment, if you lack high school education, if you have a history of a prior STI, no prenatal care, and unintended outborn delivery. So many of these things we don't do tox testing for, even pre this guidance, but a lot of people have latched on to the fact that this study says no prenatal care was associated with a positive test, and sort of cherry picking what data they want to use to keep justifying the current criteria. But this study found no association with a positive test about maternal or obstetric complications, which we know from other literature. And lastly, the Perlman and Siegel studies. So these are also single healthcare systems, retrospective studies. There's a theme here. I could keep reading through these, but they're all finding that a known history of substance use is the strongest predictor of a positive test, which makes you wonder, why did we do the test unless in those other indications? But the studies themselves also conflict, right? Some studies found association with one thing, some found association with another thing. And so it's no wonder that we're all doing this differently and that the evidence is tricky in interpretation and informing our guidelines. And the most important thing, which for those of you who have probably seen Lori Halmo, a medical toxicologist, speak, is that toxicology testing is terrible. It's terrible. It's got so many problems. It's got so many limitations. What does all the testing we do anyway really tell us? And when I ask people, oh, okay, like this is what you've been doing, what does your data show you? Most people haven't looked at it besides these few published studies. We looked at our own data where I work, and I, at the time, I think I've grown a lot in the way I've looked at this topic. I thought, oh, for sure, the reasons we're testing people are associated, and none of them were. None of them were associated with a positive test. So it's really crucial. Also thinking, okay, you get a test, but how does it help your patient? Does it actually affect your medical care at all? Because most times it's coming back positive after someone has left the hospital. And then what about all the people we don't test? Like, how do we know what we're missing? How do we know that the criteria we're using are better than criteria we're not using? So that's a hard part of the evidence too, right? You're looking at tox tests with tricky data, and the test itself is terrible. So now that I made it as clear as mud, let's talk about publications that actually maybe support some of the work we've been endorsing from Support Colorado. So again, acknowledgement that many criteria do disproportionately select for patients of non-Caucasian race, lower socioeconomic status. And some other studies have found that clinicians are more likely to ask Black people about substance use in pregnancy and test Black newborns for substance exposure than other race and ethnicity. So this Cohen study in 2023 found what we sort of expected, I guess, with the way we're doing testing currently, that there's significant difference in testing rates based on race, ethnicity, age, insurance status. Among dyads without substance use disorder, peripartum tox testing was disproportionately performed on non-white, younger, publicly insured mothers and their infants. And testing for clinical concerns further exacerbated those inequities. The Siegel study just showed that when testing is obtained at delivery, unexpected results commonly led to new reports to CPS, but less frequently to changes in clinical treatment or management of that birthing person or infant. So really calling into question, why have we been doing what we're doing? Some other studies here that I tried to really quickly abbreviate, but again, Black newborns at higher odds of newborn toxicology testing compared to all other race ethnicity. Pregnant patients belonging to minoritized racial groups more likely to receive urine drug testing during pregnancy. And this bottom part I think is really important, which is that although no more likely to test positive, birthing persons of color are disproportionately reported to legal authorities and separated from their children as a result of a toxicology test. So for all the gray of the toxicology test and which criteria we're using and what they show, there's a lot of literature coming out too that says, well, maybe there's some problems with this. And I think that's important in our journey towards implementing this guidance. I'm not a change management expert, and I might have referenced this article last time I was here, but I want to think about this more. You know, I was thinking throughout this last year, like, gosh, I'm asking people to do less. Why is that so hard? But I've learned that asking people to do less toxicology testing is actually harder probably than me asking them to do more. And so de-innovation, meaning giving up old practices, even when evidence supports that what we're doing had little value, that's really hard for people. And there's, you know, a lot of psychological biases in the people that you will work with on teams to implement this guidance that you need to think about. So confirmation bias is the unconscious tendency to favor information that confirms your prior beliefs. Availability heuristic is when people's judgments are influenced by the kind of information that comes most easily to mind when they consider a test, which is generally emotional and vivid cases. So the biggest thing I've heard in the last year to people who are concerned about these changes is, well, this one time I still remember I had this baby in the NICU, we did a tox test for something we weren't that worried about, and we found cocaine. And if we hadn't done that, we wouldn't have found cocaine. And you're like, well, okay, but like, what else, you know, ... But that's the way people remember things. Attributed causality is that psychological instinct to attribute causality to individual cases, even though you really can't see the bigger picture unless you're at the aggregate level. And then the endowment effect is when things are taken away, people tend to place an even greater value on them than they would have. And I realize that that's sort of how some people have, in my health system where I'm trying to change the policy, have viewed this. It's like, you're taking this away from me. This is what we do. And unfortunately, those people who are most vocal about it start to recruit more advocates from that perspective because of that concern. So all of this, I wish I could go back and tell myself, no, think about this way before you do this work. I wish I had thought more about this stuff before I started to approach it. So I spent a lot of time on that, but I think that I wish I had known that before I started doing this work, instead of making every mistake you possibly can in the last year at my health system with trying to implement this. So we'll switch gears and talk about opportunities for collaboration to improve these testing practices at your institution. And I don't mean to be patronizing with this. This is just things that, again, I wish I had done going back in time. But the first thing to think about is there a policy? So let's go straight through that. So if there's a policy already in your institution, great. You already have a framework. Figure out who was involved in that, who can be at the table now to start dissecting that and updating it. And if you don't have a policy, also great, because leaving it to individual clinical discretion is probably allowing for a lot of bias and inequities, and probably patient dissatisfaction as well as provider dissatisfaction. So it's a great place to start. Do we have a policy or not? If we do, or if we don't, where do I go next? Next, who should be present at this, as your core group, really looking at this policy or this issue? I made every mistake here about not having the right people at the table. Some things I want to point out is, is there someone already doing this work at your institution that you don't know about? Because if you don't know about it and try to jumpstart this work without including them, it's going to be a problem. So think about, is there someone already doing this work? Do you have in your core group representation from each discipline that interacts with the birthing person infant dyad? And do they have a wide range of experiences? Because that will help overcome individual biases. If you're having a group put together, for my system, there's multiple hospitals. So making sure not only that I have all disciplines, but that we have the right people from each location represented so that no one feels undervalued in this process. But it's easy to invite too many people to discussions about this work. And you can't make progress when there's too many cooks in the kitchen. So there's like the Goldilocks, like sweet spot of where you would go with the people who should be there. And this is a long list, but this is an example of who I think at my institution was helpful to have on board. So nurses, social workers, they are the crucial. I'm sure that's most of the people who are here, but it's just so crucial in this work. But I think if there's a clinician leading this work, it would be easy to not loop them in right away. I have on here lactation consultants with a star because I think they're important to have there if they're at your institution. And I would recommend tackling substance exposure and lactation guidance as a separate guideline or policy than the tox testing, because I think it would be easy to get too bogged down. That'd be a huge lift in one. And your EMR consultants I have on here because let's say if you're on Epic, like your Epic builders, they're not going to sit down and talk about the content of this, but they are going to be crucial with saying, okay, you've changed your guideline. We can change the order set in your EMR. We can change the newborn pathway in your EMR. And you need those people to be aligned so that the rollout happens effectively. I was asked by this group to talk about improving communication, in particular between obstetric and pediatric providers. And I don't know. I don't have a great answer to that, except that it's hard, but we have similar goals. And so some of the things that have worked for me, I have here like secure chat and Epic. It might seem really silly, but it's hard to get a hold of people via emails or get them to join your meetings. But sometimes when I'm doing actual patient care and if I can secure chat someone and say, hey, this patient did or didn't get testing. I wasn't thinking about it this way. What do you think? Oh, hey, actually, you know what? I wanted to find you anyway and talk about how we can improve this guidance. Like maybe we can talk offline. When I do send emails, just being really short, like, here's the background. Here's what I'm asking. Do you agree or not? Like not asking people to send me an entire paragraph about something. I have found it helpful in the past, also challenging, but helpful to say like, what meetings do you have, my obstetric colleagues? Can I join those meetings and talk about this? Not making separate meetings. Everyone's busy. It's really hard to find time. And again, aligning incentives for buy-in is huge. I think, at my institution, I felt like my obstetric colleagues were really interested in reducing toxicology testing. So it's like, oh, great, me too. Like, this is a great reason to talk about this. Patient satisfaction is huge, and it's been improved significantly as we change these practices in my experience, and it's overall better patient care. So it's not really a great answer to communication, but these are things that have helped. And if you figure it out, about how to better communicate, please tell me, because I could learn from you on this. Other opportunities, so identifying quick wins, like with all of our policies across all of the institutes or the hospitals in my health system, the only thing we had in common with all those policies is that all patients should be screened for substance use. Great, we agree. That's in our policy. Like that's a quick win. The other stuff's going to take longer. I think that stigma bias training is really important to talk about in this work, and it's really important for the people involved in this work and those affected by the rollout to have that training. And I know CPCQC offers potentially a stigma bias training opportunity. So leverage what's out there. You don't have to do your own if you have someone who's an expert who can do this. And then the other thing is that there's tons of resources out there, and there's lots of local experts. So I have some of the websites for some of the resources you can find. And I have my own email, because if you email me and there's something I can offer that I used in a presentation or that I know about, I'll be happy to message it to you. But it's silly. Like I've spent tons of time working on something just to find out something already existed that I could have just quickly moved on from in my rollout efforts. And so those are, I think, opportunities that can be leveraged. Informed consent, it just was another goal for this presentation. And so I just wanted to model how we do that. And at my institute, we have done informed consent for newborn testing the whole time I've worked there in the 10 years or so. And so this is probably old news to everyone here, but informed consent entails explaining why the test is indicated, what type of test will be done, what are the benefits of the testing, but also what are the risks of testing? And if the test is refused, what are the benefits and risks of that? Always consult with your legal team at your institution and make sure that there aren't other components that should be included in your institution's specific consent. But in general, these are the tenets of informed consent. I will say that, yeah, there are times where tests might be performed when consent's not given, but those are rare exceptions. And for toxicology testing in particular, it might be that the birthing person comes in to deliver, is altered or has some severe medical conditions, and they're not in a place to give consent, but it's emergent, and same for newborn. If there's a really emergent need, which is rare, but if there's an emergent need for a newborn, okay, maybe you would send it without explicit documented consent. There are times, and hope it's becoming less and less, where the county has custody of the newborn and they might ask me to send testing after that, but that's rare as well. This is my dot phrase. It was really hard to take a dot phrase in Epic with all the drop-down menus I created and put it in a document to show you on PowerPoint, but the dot phrase that we use here, we use verbal consent in our institution. We felt like, having a separate paper to sign, it was sort of like this weird power dynamic. And so the verbal consent, and the way I discussed it is say, hey, after I've had all the discussion about just what's your baby's name, where are you going to take them for a pediatrician? What is the plan going to look like? Additionally, I saw that you had a positive test for this. Can you tell me more about it? And if they say, yeah, I was, and I say, hey, I don't know if these are the things I might think about for your newborn. Sometimes methamphetamines is contaminated with fentanyl in Denver. Were you aware of that? I mean, we could look for that in a tox test. Here's why we would do a tox test in this case. And our policy is not updated yet, so it conflicts with what we're talking about as the new guidance. But that testing would include umbilical cord tissue. It's already saved. We don't have to take it from your baby. And that tests for things like marijuana, cannabis, or that is the same, but opioids, amphetamines, cocaine, that sort of thing. If the testing is positive, it might change the way we follow your baby if it comes back positive while you're still here in the hospital, but also after discharge, and I explain some of the stuff on the screen. And in the end, I say, it's not automatic positive testing equals a CPS report, but there are times where we might consider a report to CPS. And I want you to know that that is another potential outcome of this test. And do you understand? What questions do you have? And a lot of people who are concerned about doing informed consent for newborn testing say, there's no way people are going to say yes to this. But you'd be surprised. We average maybe one a month that decline this testing. And then that's the birthing parent's right. So I don't know. I give this conversation all the time. It doesn't faze me at all in like I'm not worried about it. But a lot of people who haven't had this conversation before they do the testing are worried about it. All right. Lastly, next steps. And I'm sorry if this is getting redundant, but again, assess current state. Think about your core group who will do this work. Gather resources early. And maybe if you can learn anything from me, think about some of the things I've tackled in terms of like what people are saying they're concerned about with a policy, and anticipate that early so that you are prepared upfront to address that when you bring this to your institution. Leverage existing educational opportunities, even in your own organization. So for us, I know sometimes the nurses have journal clubs. Well, great. Like, why don't we do an article from one of the ones I had here? And maybe that can start prompting conversation to generate interest in this. This is something, the last point here, that I think is really helpful that I didn't do and I wish I had, which is, getting some contact with your local CPS representatives, because if what you're doing in the institution feels very different than what the county's telling you on the phone, that's going to make this work really hard. And so making contact with your local CPS representatives early is great. And Shannon Bryan from CPS, it seems very open to facilitating those contacts if you need help with that. I would recommend, in terms of dissemination, that you start by telling people, hey, the law regarding child abuse and neglect with substance exposure changed in 2020. I didn't do that. I thought everyone knew. No one knew. And so this felt like it was coming out of left field, all this guidance. And so I do recommend, maybe if you're going to start somewhere, making sure people at your organization know that. Then you can talk about, hey, well, once that changed, people start thinking about what's best practice for this. And then they actually issued this document. Here's a one-pager about it if you're interested in reading about it. Okay, now how can we bring this work to our institution? So takeaways, I guess, sorry for talking so fast, but the takeaways would be that, this best practice guidance is already published. So use it, please. Evidence exists in the literature, but it's not great. And evidence isn't the only driver of change for this work. So just keep that in mind. Get the right people at the table early. Anticipate confusion, questions, pushback, but address it and keep going. Use the existing resources you have, especially through this group, CPCQC, and use existing resources at your own institution. I'm going to skip through this one because it's redundant. Here are a couple of resources that I think are helpful. And I just put this in last to end on a funny note, because I felt like this is how the organization felt when I came to them with this. Like, what if we don't change at all and something great just happens, right? Like, it's not how it works. But then to myself, to the left, I always tell myself, like, we don't want this to just stay a good idea. When I feel like giving up, I'm like, no, like, keep trying, experiment, reiterate, try again, change the world. Like, I want to encourage you to feel that way too, because you will come across setbacks and challenges in this work, and it's still worth it to keep going. And here are some of my references. So I'll stop sharing, let you guys take back over.
Wonderful. Thank you, Dr. Gold. As we get back to the presentation, does anyone have any questions? Feel free to enter those into the chat or come off mute. I know some resources have been shared in the chat, so that's great too. And of course, we will send those following with the meeting notes and the presentation. Any questions for Dr. Gold? Okay, well, thank you so much for joining us today, Dr. Gold. If we receive any questions from the chat or in an email, we will be sure to get those to you. And again, those resources that were shared in the chat, just wanted to remind everyone of the 2023 Illuminate Support Colorado guidelines. Again, these links will be in a follow-up email. There are some great videos out there, some guidance documents that, like Dr. Gold said, are already evidence-based. These resources already exist, and we will be happy to share those again with the group. Okay, now I will pass it over to Dr. Steenberg and Dr. Schultz with Denver Health.
Hi there, everyone. I'm just going to share my screen here. Looks like you guys should be able to see that. Okay. My name is Dr. Steenberg. I am one of the OBGYN generalists at Denver Health, and I am very excited to be giving just kind of a quick update on what we have been doing at Denver Health in terms of our implementation. We're getting very close to being fully rolled out in terms of kind of everything that we've been working on over the course of the past like 1.5 years or so. And I've been working very closely with Dr. Stefka Fabry, and then also Dr. Schulte, one of our third-year residents, who I embarrassingly had to ask earlier this morning if she was a fourth-year resident, because that's how amazing she actually is. So I'm going to hand it off to Vera, and then Vera, if you just want to let me know when you want me to advance the slides.
don't think we can hear you, Vera.
Can you hear me?
Yep, you're good.
Okay, great. Sorry. I just wanted to start off by saying I'm really happy to be here. Thanks so much for letting me join and participate in this wonderful community that's doing so many good things for our patients. I wanted to start with a little case study. This just happened a few weeks ago, and I just thought it was a really good example of, the fact that we have come very far, but there's always things that we can continue to improve on to take care of our patients. So this is a case about a 32-year-old who came in at 36 weeks with painful contractions, and she was found to have a new diagnosis of severe preeclampsia when she was in the OB screening room. She came in around 1 o'clock in the morning. For these reasons, she was admitted for an induction or augmentation of labor and a magnesium drip for her preeclampsia. When she came in, she was very honest and open about her substance use history. She reported 5 years of opioid use, intermittent cocaine use, and smoking about 5 to 7 fentanyl tabs a day. She had had intermittent interactions with the healthcare system prior. She had a baby in 2021 and shortly postpartum presented to the ED in withdrawal with a desire to start methadone. Unfortunately, she was lost to follow-up and reported relapse afterwards. In August 2023, she was newly pregnant and came in for an OB intake visit and again desired to be connected to additional treatment options. The referral was placed. She was scheduled with Dr. Klee, one of our family medicine doctors who specializes in opioid use in pregnancy, but unfortunately never sought further care and was lost to follow-up. And then she presented just a few weeks ago to the OB screening room with no prenatal care throughout her pregnancy. Next slide. Her past medical history is really just notable for her substance use disorder. Her OB history was notable for prior severe preeclampsia in a pregnancy in 2021, requiring a forceps-assisted vaginal delivery. Unfortunately, her neonate passed away at 5 days of life, secondary to sepsis. So when we initially spoke to her about her substance use, the providers were very thoughtful about using non-judgmental language and mirroring the patient's language. We discussed the options and if she was interested in initiating methadone versus buprenorphine, leaning towards methadone because of her fentanyl use history. And she was also very motivated to try methadone again. She reported withdrawal symptoms and was scoring mild to moderate on her COWS. So I wanted to initiate methadone for her. We did not perform a urine toxicology when she came in because one, she was very open about her substance use history. Two, she seemed to have a lot of trauma and wariness about the healthcare system, especially given her history of neonatal loss. And the benefits certainly did not outweigh the risks of doing urine tox on this patient. I tried to order her methadone and looked through the Denver Health Policy Stat, which we use for pretty much everything that we do, especially on labor and delivery, because it has such a great set of standardized recommendations for our patients. Unfortunately, I found that there were 2 exclusions for methadone inductions, and one of them was if the patient was in active labor. So I was unable to initiate methadone. The patient, this was shortly after she was admitted, around 1:30 or 2 a.m. And the patient was reporting pretty significant withdrawal symptoms that did not improve with Ativan, Lamodal, or other PRNs. She got an early epidural for pain management, but due to her significant anxiety, the epidural came out because she was moving around a lot. So at that point, I decided to consult addiction medicine, which doesn't really exist overnight at Denver Health. So I consulted psychiatry and spoke to the psychiatry attending overnight and reviewed kind of the recommendations for initiating methadone. We also looped in the nurse that was taking care of the patient, as well as the pharmacy team that was on overnight, to see if we could override this exclusion for initiating methadone in active labor. And we all came to the conclusion that we absolutely should do that based on the patient's significant withdrawal symptoms. I also did a lot of review that night to see why we couldn't start a patient on methadone while she was in active labor. And ACOG basically had no reasons for that. So I reviewed the practice bulletin number 711, which discussed like opioid use intrapartum and methadone and buprenorphine. And there were no recommendations nor any contraindications for initiating methadone in labor. And it seems like it's not something that's been studied. So there really wasn't a reason for us to not start her on methadone, given that that was the best thing for the patient at the time. So long story short, she came in at 1. I wanted to start methadone at 2. She got her first dose at 6 a.m. So it was pretty delayed that we were able to give this patient the care that she needed and deserved. She was initially very sedated from the methadone. And it was interesting because we had several conversations. She delivered shortly after methadone was started that morning and was still on a magnesium drip. And then questions started to come up about whether she was withdrawing from some sort of stimulant like meth, even though she did not endorse any meth use. And I thought it was very interesting that that was the first reaction that a lot of providers went to, because we have a lot of iatrogenic reasons for her to be sedated. And she also just had a baby, which in and of itself was a great reason to feel really tired. So I think we tend to lean more heavily on accusing substance use for things that could be explained by other reasons. And it was just a reminder that we should not always blame everything on substances in those patients. She eventually was up titrated to 90 milligrams daily of methadone and went home with that with outpatient follow-up.
Awesome. Thank you, Vera. So to give a little bit of background about Denver Health, and Vera kind of ventured into this a little bit in regards to the policy stat, but Denver Health, it's a unique healthcare institution. We act as the safety net hospital in Denver. We have approximately 3,500 deliveries per year, and the obstetrics care is provided by a combination of family medicine providers, certified nurse midwives, and OBGYNs. All providers provide medical care in a hospitalist-like model. But we feel very lucky to have the benefit of addiction medicine and psychiatry consulting services. But as Vera mentioned, the limitations of these services is that they're mainly only available during business hours, Monday through Friday from 8 a.m. to 5 p.m. And although psychiatry is technically available 24/7, oftentimes they will say well, we'll wait to see this patient until the morning or on Monday. And for example, this patient could not wait. We all know that pregnant patients certainly present at all times of the day and the week. So we really wanted to, an important part of why the OB providers, including family medicine, nurse midwives, and OBGYNs wanted to take over some of this care at Denver Health, was to ensure that we could provide excellent care for any patient affected by substance use at all times of the day and night. The last unique thing about Denver Health that I wanted to highlight is that the majority of our practice is driven by guidelines and what is known as policy stat. I recently heard someone describe this as the Wikipedia of Denver Health, which I think is the perfect explanation of policy stat. Of course, we all continue to use our own clinical judgment, and the guidelines provide just an outline of how to provide evidence-based and non-judgmental care for many different conditions, including, as of last week, substance use disorder in pregnancy, which we're very excited to finally have kind of on the books and an easy way to follow and ensure all patients are getting very similar treatment. This represents only a small portion of the key stakeholders that have been involved in the implementation of our policy changes. The OBGYN clinics involve not only an expanded group of providers that are able to appropriately treat and counsel patients affected by substance use or opioid use disorder, which we have opted to name PAIR providers, standing for Perinatal Addiction and Recovery, but also the OBGYN nurses that are responsible for doing the 5P screening at the initial intake, and thus being the first point of contact for these patients. And perhaps more importantly, these patients' first judgment and how they're going to be treated within our system. More broadly, it also involves the medical assistants and the front desk staff, all equally important in that patient's experience. The postpartum unit is essential for helping patients navigate now's admissions if needed, ensuring appropriate follow-up currently at a minimum of 1 week, 3 weeks, and 6 weeks, and connecting with social work and peer recovery supports to ensure a safe plan of care after discharge. As of this week as well, we have had a lot of new rollouts as of within the last week or so, but Labor and Delivery has introduced a new screening process with 5Ps being performed at the time of birth admission. And as seen from the case study, an important part of this patient's journey. Social work is involved both outpatient and inpatient, and we have worked closely with the addiction medicine social workers to allow for a linkage-only consult, meaning that we can already utilize the addiction medicine social workers who know all of the best places to send patients for additional resources once they're discharged, instead of reinventing that wheel, but still allowing us as the OB providers to provide medications if we deem it's safe and appropriate to do so. Pharmacy has been essential in reviewing the MOUD induction protocols and also ensuring a smooth rollout of both outpatient and inpatient naloxone for take home. And then just a few more, the Center for Addiction Medicine, which has been key in helping us establishing workflows for both outpatient and inpatients. They are the glue that helps hold together the many different happenings at Denver Health together, and trying to really help to decrease the amount of silos. When we started this work, we realized there were so many different components that were happening, technically involving the OB population, that as OB care providers, we had no idea were happening. The community programs, we have partnered closely with Hard Beauty, which we were introduced to through Moms Plus, to make the referral seamless. And then lastly, the primary care clinics. As I mentioned, we have an integrated model of care, and family medicine provides a significant amount of the OB care to patients delivered at Denver Health. They have been an excellent resource, as they're actually already prescribing methadone and buprenorphine and providing counseling in an outpatient setting. So all primary care clinics at Denver Health also have a substance treatment counselor situated within their clinics. Prior to Moms Plus, this was not a service that could or was utilized by OB patients, but as we're currently developing schedules that will actually allow for these substance treatment counselors to be paired with an OB pair visit. A lot of pairs in there. So a little bit about our integration. So we have taken a multi-pronged approach to overhauling our current care for patients affected by substance use or opioid use disorder. The first being prevention. We have rolled out expanded universal screening, both at initiation of prenatal care, at birth admission, and then also at the postpartum visit. We are simultaneously screening for coexisting disorders such as anxiety and depression, including a new screening for post-traumatic stress disorder, specifically at the postpartum visit related to delivery. For destigmatization, we have worked and continue to work on all levels to address discrimination, especially kind of throughout every single different contact point the patient could have, from nursing, medical assistant, front desk staff, physicians. We're continuing to work on how to incorporate pediatric providers and nurses into our current education model and hope that we can continue to expand this. It's already been started a little bit, but certainly an area that we can continue to work on. And one area that we're especially proud of is our connection with Hard Beauty. I mentioned this on the last slide, but we have worked very closely with them to develop a referral program that allows for any patient interested in peer recovery support to have access to additional assistance in the recovery process. As someone who has put in 2 referrals myself over the last couple of months, I've been incredibly impressed by how quickly they have responded, truly within less than 10 minutes, and how grateful the patients have been for this care and to have someone else that they really feel like is on their team. I won't spend a ton of time on this slide because we're going to get a little bit more into this, but harm reduction, getting naloxone, both outpatient and inpatient for all of our patients. Standardization of clinical practice. This is something that we've been prioritizing from the beginning, but toxicology testing and also CPS reporting. The CPS reporting is still a work in progress. And then for the MOUD treatments, establishing treatment protocols, and then that provider group expansion through the OB pair providers. So the pair providers, kind of how patients get to them is that if there's a positive screen, with marijuana being the exception, then the nursing staff who is doing all of our OB intakes will document an SPART and then refer to pair providers, which are a combination of certified nurse midwives, family medicine, OBGYNs, and then, as I mentioned, that substance treatment counselor, which is a really exciting part that we were able to kind of integrate in and already was established within our Denver health system, but not something that we were previously accessing for OB patients prior to kind of the initiation of this rollout. Dr. Gold mentioned this in her PowerPoint as well, but it's hard to distill an epic smart phrase into a PowerPoint slide, but this is our standardized checklist that all OB pair providers will be now using at Denver Health, and is kind of goes through in a systematic way of making sure that all the little checkpoints are met and that every single patient affected by substance use disorder or opioid use disorder is receiving the same care. And then lastly, I know this was something that we definitely wanted to touch base on based off of Dr. Gold's amazing presentation prior to this. And you'll see that there's quite a bit of overlap. So I'll be able to skip over some slides pretty quickly here. But this is our toxicology policy that we've recently had approved, probably honestly close to 6 months ago. In terms of, it's funny how different things work at different institutions, because in terms of things that we were able to roll out and do quickly, this was one of the things that we worked pretty quickly on using the Support Colorado testing algorithm. And we're able to move this toxicology guideline quickly through our policy and procedures committee. The way that we did this, and we recently learned that this was slightly different than how other hospitals approached it, but we actually kind of divorced the maternal or birthing parent toxicology indications from the neonatal. We knew from our initial conversations that there was going to be more of that pushback on the neonatal side. So we decided that ultimately, as OB providers, we don't dictate the care for the neonates, and we don't necessarily tell them how they should care for the infants. And flipwise, they don't tell us how we should provide OB care. So for us, it was kind of an easy solution to like, okay, for right now, let's take one win and let's get the birthing parent toxicology guideline through, which went through honestly pretty seamlessly and without much hesitation, a lot more enthusiasm. But essentially our indications was what Dr. Gold already talked about. It was a short policy, which was nice, but just those 3 indications, and there was nothing else in there other than that you should obtain consent prior to ordering any type of urine toxicology. In terms of what our next steps are, so we are continuing to work on the pediatric side. We have a lot of support from the pediatric department, which is awesome. We have a lot of faculty, and including the chair of the department, that are very supportive of this effort. So we're very lucky in that sense. There's kind of a few different things that we would like to do. We would like to be able to make referrals to the pediatric department so that the birthing parent who is affected by substance use or opioid use disorder can talk about a now's stay prior to them actually being admitted for those minimum of 5 days, so that they can know what to expect. They can know what they can do to help their baby once their baby is born. But some of the logistics that we're running into is figuring out how to schedule adult patients into pediatric clinics, and then also the billing side of it. How can you bill as for an adult patient in a pediatric visit technically? And then we're also continuing to work on modifying our breastfeeding guideline, which is, I know, a work in progress and hopefully will be released soon to be less punitive against these patients. And then also in neonatal toxicology guidelines. They're aware of the law, they're aware of the guidelines that are out there. And I think having us kind of put through the birthing parent toxicology guideline was a nice kickoff to say, like, look, we did this, you guys can do it too. And I think that's all I have. So I'm going to stop sharing my slides here.
Wonderful. Thank you for all of that information. Does anyone have any questions for the Denver Health team? Okay, well, I know we're getting close to time. Let me reshare my screen. And then I will pass it over quickly to Rachel Duncan with Moms Plus.
Hey all, thanks for having us today. My name is Rachel Duncan. I use she, her pronouns, and I am program director of Moms Plus, which works super closely with CPCQC's other perinatal substance use disorder QI programs like AIM SUD, as well as Chosen. Thank you both for the wonderful presentations today with Dr. Gold. I threw in a couple links there to her actually giving that lecture that you can take back and share with your facilities. So you can just carry Dr. Gold in your pocket wherever you go. And then thank you also to Kylie and Vera for that wonderful just update on the work that's happening at Denver Health, and just so encouraging to see such a big machine move pretty quickly, quite honestly, due to those champions. This is a great video here that we were fortunate enough, and I'm also putting that link in the chat there, to partner with a lot of our moms in recovery through Hard Beauty organization, as well as some of our social work champions. Shannon, who we've mentioned here before from CPS, also appears in this video, but it's essentially really getting at the heart of what we're talking about today when it both comes to toxicology testing practices and how that, of course, interplays with us being mandatory reporters and what that looks like. And so this video is really all about us really transforming ourselves from this mandatory reporting punitive approach to a mandatory responder therapeutic approach. And so that's actually the name of this video, is just mandatory responder. It's about, I think, a 10 to 12 minute video. If you would like to take that back and watch it, get out the tissues. It's going to really pull out your heartstrings here and just really have stories of moms who have gone through these experiences. Helps us really think about the trauma that can cause. And I think, Vera did a good job of kind of alluding to that with her patient and having some traumatic experiences in the past there with testing and reporting. And of course, just losing a child, right? And so it also gets at that law change that we've talked about today. This is really meant to go back and change the hearts and minds of those in your institution, for those that maybe aren't on board with some of these newer recommendations. So feel free to share that. It's a great start to like a staff meeting, or just to maybe share on your hospital website if you're trying to get that message out of, hey, we're trying to change practice here. We want to be the place where if you are affected by a substance use disorder, you run to us and we will respond therapeutically. So I hope that you're able to use that, and that's, yeah, free for you all to use. So that's all I have to say. Thanks, Sarah.
Thanks, Rachel. One more thing before we let you go for the day. I just wanted to do a plug really quickly for the Moms Plus CPCQC Lunch and Learn that we'll be hosting next Thursday. And we will be sending out an updated flyer. We realized that there were some registration issues, but we want to make sure that you guys have the most up-to-date information. Actually, I apologize, it's on the 14th, not the 15th. So if you are not registered and would like to be, please scan the QR code. And again, we will send this out in an email for you to use as well. Okay, looks like we're at time. So if anybody has any remaining questions, feel free to unmute or put those in the chat. But otherwise, we will see you on March 14th. Be on the lookout for quite a few emails with us with resources, invitations to host site visits for those new sites. And thank you so much for attending today.
Thank you all so much for coming. See you guys later.